Evening, everybody. Evening. I'm so delighted to see so many people here, and I'm so excited that Sally has come to talk to us tonight. I've heard a version of this talk, and it's absolutely brilliant. And there'll be no pressure. There'll be so many valuable take-home messages for us all, I'm quite sure. She is happy to introduce herself, or prefers to introduce herself. She's going to talk for about an hour, and then we'll have a time for a few questions, and then there's wine and some apparently some Scandinavian festive treats outside, so do stick around and we can all network and catch up with each other afterwards. So I'll hand you over to Sally. Thank you so much for coming.
Lovely to see so many people here, and thank you for giving up a Thursday just before Christmas, which I know is peak party night tonight, so very well done for not partying, or not partying yet. Hopefully you can go on from here to do more fun, festive type of things once you've had your glass of wine and your Scandinavian nibble. As Fran said, I'm Sally Davenport, and I am a physio by background, but for many years I've been in education, and I currently work here at UCL, and I lead an MSc in Neurophysiotherapy here at UCL. And my work sort of spans, what we'll sort of cover tonight is it sort of spans the link between education and educational theory and patients as learners, and that's what we'll sort of cover as we go through today. So say about an hour. I've tried squeezing a lot, so it might be quite fast at times. And when I see you all losing the will to live and needing the glass of wine, I'll just draw it to a close, and then we'll go and have a drink afterwards. It's so going to go through trying to span a little bit from acute all the way through to rehab, all the way through to home, and just to try and give a flavour, because I know we've got different people from different areas, so hopefully you can all take something from this. Just a little bit, just to give me some orientation, and I'll look mainly to this side of the room because that's where most people are, but I'll try and look at you a little bit over there as well. Just to get a little bit of a flavour, we're going to talk quite a lot about physio and OT predominantly tonight, but a little bit about some of the other disciplines as well. So from the physios in the room, are you able to identify who's a physio in the room? Okay, lovely. So you can all sit and feel very smug at this point, and just you'll hear wonderful things about yourselves over the course of this talk. And I'm sure you're wonderful people, and I'm sure you're wonderful physios. But hopefully what we'll come to sort of tease out a little bit is actually just by dint of being a physio, all your patients are going to love you regardless of what you do. I'm sure you're brilliant, but just your smugness might be a little bit tempered by that. And OTs in the room. So we've got a little handful of OTs. Now, you might find this a harder hour to listen to coming up, but what I hope to be able to cover is why it's so hard for you and why patients struggle in some regards with that role as an OT. And say, again, you're doing brilliant and wonderful things, but just how it's perceived, and that's some of the things that we'll go over tonight. So just as some prior warning, just to give you that context, that don't go away too miserable from today's talk. Because they do love you, just in a sort of roundabout sort of way. So that's tonight. So let's get going, and that's a little nod to festivity. And hopefully this will work. Oh, it was working earlier. Let's try that again. If not, I'll just go with that. Oh, no, none of it's moving now. Let's see if we can click on that.
You're right.
Oh, yeah, just got stalled for a bit. So we're going to romp through Christmas in a couple of weeks' time, and you'll do your celebrations, and that will all be wonderful. And then you'll arrive at the 1st of January, which will be less wonderful, because you'll be sort of shortly returning to work if you're not at work already. And come the 1st of January, you'll be thinking to yourself, okay, New Year's resolutions and those kind of bits and pieces. And so you might decide that you want to join some type of group activity and be doing something with other people, perhaps to get fitter or to meet new people, etc., etc. Or you might be thinking to yourself, I need to do some new skill and learn a new activity and sort of test myself with something different. And so that's what you might be doing on January the 1st. And the big question is, will you still be doing those things on January the 31st? That's what we want to know or not. So will you have started and stopped, or will you have started and kept going? So what we're hoping to cover today is really to increase the understanding and really think a little bit more about enhanced engagement. So how do we get people into things and keep them there and keep them staying there for the longer term, rather than starting something and stopping, or perhaps not even starting in the first place. So that's what we're going to be focusing on, particularly related to people with stroke and other neurological impairments. So when we come across a new activity, a new situation, a new learning situation, something that's different and novel to us, there's always a boundary that we need to cross at that particular point. So if it's going to an exercise class, it's going to choir, it's starting a pottery class, or whatever it was on the previous slide, we've got this boundary, and therefore we've got a point of negotiation. And you've got to decide at that point, do you cross that boundary or not with that new activity? So do you say cross it, do you join, do you step into it but then step away from it? Do you say taste it and sort of think, am I going to go back or not? But that's a decision you need to make. For any of you that can be sort of thinking about something that you might have joined recently or sort of in sort of, recent times, and sort of thinking, what made you go back again at that stage? What stopped you from stepping away and thinking that's not for me at that particular time? So that's what's really important is what is it that enables people to step into these activities. So what shapes and influences that, and what enables people to step across a boundary at a new learning situation that they find themselves in. And so we're going to think about that in two different contexts today. We're going to think about it in relation to supported rehabilitation. So for those of you that work in a sort of more inpatient setting, what is it about stepping over that boundary for patients if they're in supported rehab? And then we're also going to think about self-supported practice as well, hopefully time allowing. And that might be self-supported practice in hospitals that you might be wanting your patients to do if they are an inpatient, or it might be work that you're wanting them to do at home at that stage. So sort of thinking about those two different boundaries, how do we get people to cross over and into those spaces to actually inhabit those spaces as part of their rehabilitation? So we're going to think about both of those two different aspects. We're going to look at, as well as we go through, the sort of thought that if we do supported rehabilitation, people will automatically do self-supported practice. And actually we're going to unpick that and look at that relationship between those two aspects and how that isn't actually a very strong relationship about what we might do in an inpatient setting and what patients then pick up and do by themselves. So that's sort of where we're going to go over the course of today. And we're going to start with that supported practice, supported rehabilitation in that sort of inpatient setting. So, relearning functional activities is what we want our patients to do, and that might be exercise, it might be, and that might be physical, it might be OT related, it might be speech and language related, it might be that they're engaging in some type of activity from psychology, but often we're wanting people to engage with something as part of their recovery, and that's either post-stroke or people living with neurological impairment. And we know quite a lot about learning. There's been lots of research that's been done over the years, particularly related to motor learning, so we know lots of principles of motor learning. We know that intensity is important and repetition, and we know that salience is important and motivation and all those kind of aspects. But what we know less about is what's it actually like to do that learning. So what's the more behavioural aspect? Who are the people who are doing that learning? And what is it actually about being asked to do that learning, having to engage and take on that learning? And that's something which, from a sort of an evidence point of view, isn't something we've particularly explored about what is it like to be a learner in those situations and actually to have to do that learning and say in this first instance in supported rehabilitation. So that was the focus of my particular research. And I set out to look at this aspect of learning. So where do people do the learning? How do they perceive the learning? Where do they feel the learning takes place? What factors influence the shape and direction of that learning? And so what is it like to be a learner in those situations? And it's particularly the making sense of the learning that we're going to share in this lecture tonight, as we're thinking about what does it mean to patients, how do they make sense of what they're experiencing? And that's going to help us understand a little bit more about crossing over that particular boundary. So because it's learning that we're interested in, just a couple of thoughts about learning itself, just to have in mind as we go through today's session. So if we look at the derivation of the word learning, what it means is to find or furrow, to follow a track. That's what the actual word learning means. So it's to find your way along a pathway, along a track. And that's what our patients have to do. So here we've got a diagram of thinking about people in the stroke setting. So from somewhere from the hyperacute all the way through to home, our patients have to find that pathway. And we want to try and help them first step onto that pathway and then stay on that pathway all the way through. So that's what learning means, is navigating that direction. But what's really important to recognise is that to gain mastery, so to learn, what it means is that you have to step into the unknown. You have to submit to the unknown. If you know what it is that you're going to be doing, then you don't have to do the learning in the first place. So learning is an incredibly vulnerable thing to do. And I know that a number of my students are planning to come tonight. I can't see any of them here particularly, and they have got an essay tomorrow, which is probably why they're not particularly here tonight. And they'll know all too well about this idea of stepping into the unknown. You know, they've come from overseas, they've come to a different country, they've taken time from work, and so it's a really vulnerable thing to do, is to put yourself into a new learning situation, which means that learning can have the highest of highs, so it can be a real triumph to do learning, but it can also lead to the lowest of lows as well. So it can take you to some really deep and dark places if that learning doesn't go well. And it's not going to the track and the course that you wanted it to go on. So say it's a vulnerable position to be in, difficult for some people to do, and it can take you really high, but it can also take you really low, and we'll see that when we have a look at this and how it relates to our patients in that post-stroke period. So my work looking at learning was an ethnography, which if you ever have the chance to do research is a fantastic research method to do, because you basically go and sit yourself in a corner of a space and watch the world go by. And if you're nosy like me and you like watching people in the world, then it's just fantastic. So I plunked myself in a rehab unit and I sat there for 2 summers watching the world in the rehab unit and how it operated to really try and understand learning. And learning is quite a nebulous thing, so it's quite hard to watch, and it took time to get a feel of what it was that you were watching over that time, but gradually got a sense of what was going on in those places. I didn't go to the acute setting, but the patients all talked about the acute setting, so I'm going to share that with you today. So particularly any of you that do work in that very early stage, hopefully that'll be interesting for you. And then I followed the people up when they went home as well. So I did about the first sort of 6 to 9 months of that post-stroke journey. So that's sort of what we're going to share today. And universally, from the people that I worked with as part of the research, they all loved the rehab unit. And we'll talk about why they loved the rehab unit. Without exception, they all found the acute setting a really hard place to be. And again, we'll have a share of that. And home was quite an equivocal place, and that really depended on how much more recovery those people were hoping to do. So for those that could go home and could generally settle back into life much as it was before, home was fine. For those who still wanted to make recovery, home was quite a tough place to be. And again, we'll try and share some of that for those of you that work more in the community and hopefully get a feel of that. So if you're a qualitative researcher, you then bash your head against a brick wall for many, many months to try and work out why. Why were the people feeling this? And that's, say, what we're going to talk about today. So what it came down to from the analysis that I was doing is, were these places that made sense for recovery? Did the people feel, the patients and their family members, did they feel that this was a place that made sense for their recovery at that time? So did the place make sense? Did it physically, the environment of the building, did it make sense for the people for their recovery? Were the other people, so the staff, did that make sense for recovery? And then the policies and the processes and the practices, so what was being done, what they were being asked to do, did that make sense to people or not? And those 3 things came out really strongly and say we'll share today. And if we're thinking about crossing boundaries, a couple of things that we're going to talk about. Was it visible? What did they see in those places, and what did they not see? So was the boundary itself visible or not to them? And what did they see of those places? What were they picking up? What weren't they picking up? What was invisible to them? And what did they find invitational, and what did they find disinvitational of what they were experiencing? And these were things that came through that we'll talk about in relation to each of these different places. So when we're thinking about learning, we're going to think about who is the person doing the learning. So there's always someone doing learning, and they're learning something that we'll touch a little bit on today for a reason, and that's a question that we don't ask much in rehabilitation, but is certainly something to ponder on, is what's the purpose of rehabilitation? So it's a question that's asked a lot in education. What's the purpose of education? We don't really ask it in rehab. It's not a question that's been particularly asked, but it's a really important question to ask, thinking, why are we doing it? What's the real purpose of doing rehabilitation at that particular time? It's not as straightforward as it might seem. They're learning from someone who's doing something somewhere. So these are all really important things that we could and should be thinking about when we're thinking about the rehab that we offer. So, who are the someones of rehabilitation? And you can ponder in your mind, who is your patient group? Who is it that you work with on a day-to-day basis? So who, if we're thinking about visible and invisible, who is doing the looking? Who is seeing, what is it that they're looking for at those particular times? What are they wanting and what are they expecting? So this is, who are the people that you're working with is going to be important when we think about crossing that boundary and engaging in rehabilitation practice. So to give you a sense of the people that were involved in my research, these were the people that I particularly included. There were lots of people on the rehab unit, but I had 14 people in particular that I did longitudinal interviews, so multiple interviews with over sort of 6 to 9 months period. Predominant males over females is who came in at that particular time. They were all white British, and so you can think about that in relation to the people that you work with. They all had been or were employed sort of prior to their stroke, so they were sort of socioeconomically advantaged and educated to an extent, and all bar one owned their own home. They all had a degree of sensory motor deficit. I was looking for people that were engaging in self-supported practice, so they had enough cognition to engage in self-supported practice. They were all mobile on discharge, bar one, but 6 had quite marked upper limb deficit on discharge. So looking at that, you can just take a gauge of sort of thinking, does that look like your patient group? Does it feel different from your patient group? Just to get a sense of what that might be as far as the findings are concerned when you compare it to the people you work with. So those are some of the features we tend to think about the people involved in rehab. Some of you will know this because some of you have heard me before, but here are some features that we perhaps don't often think about when we think about the people that are involved in rehab. So the patients that we work with, predominantly, I presume, in the room today, are adults. So they're adult learners. They're learning at a point of disjuncture. So they're often learning from need and not from choice. They've had a stroke, they have MS, they have Parkinson's, they're having something, so they're having to learn from need and not from choice. They're learning towards an unknown future because they don't know what it's going to look like. What are they learning towards at that particular time? And they're very often newcomers or novice learners. And even people that have lived with conditions for a long time, if they're coming to you at that stage, something has changed. So even they, although they might be experts in their condition, they may well be newcomers to how their pathology has progressed to that new situation at that time. So very often they're inexperienced and so they're novices in that situation. So those are the factors that you might not necessarily have thought about in respect to your patients before, but are really important factors when we're thinking about learning and what our patients do as part of their rehabilitation. So, I'm going to think about being adult learners to begin with. And for any of you who have done any kind of reading around or thought about this concept of the enriched environment, if you bring to mind what evidence that's based on, and what kind of pictures are often put up if any of you have ever been to a lecture on the enriched environment, quite often the evidence that's based on and the pictures that are put up are these. Mice running around cages with things to run in and out of and up and down and through and all those kind of bits and pieces, or children playing. So you often get shown a nursery, a picture of an inside of a nursery that's full of all the stuff, and then you'll be shown a picture of a stroke ward and a bed, and it'll be really deprived, and you'll be shown this contrast and say, look how engaging and enriching a nursery scene is, and look how deprived your person in a stroke on the ward in hospital is. And that's great, that's true. But our patients we work with are neither mice nor their children. They're adults and they're adult learners, and that comes with really certain characteristics and things that we need to think about to sort of think about their engagement with their rehabilitation and their practice. So, as a child, the world is all about exploration. It's all about, and actually if you're a mouse or a rat, it's all about exploration as well. So it's all about, huge enthusiasm for the world, put yourself out there, throw yourself into it and explore. So that's early childhood. Adolescence is still about exploring the world, but it's really to do with your identity. So it's all about, any of you who've got teenage children will know all about identity formation in your teenage children. And it is about exploration, laying down schema, but very much about who they are. In adulthood, it's different. In adulthood, it's all about stability. You've got your identity, you've worked out who you are, you've got your schema in place, and you want to try and hold on to that as much as you can. So you're happy to use what you can about 80% of the time, happy to be wrong about 20% of the time, but in essence you don't really want to change particularly often in adulthood. You're happy to try the new choir or the pottery class, but you kind of want to stay as you are as that individual. So it's not about exploration so much at that particular stage. So if we had to bring together some of the characteristics of adult learners, these are some of the things that are really important for us to think about and hold on to, and why it's so hard for us with our roles, with our patients, why it's so hard for them to engage in long-term rehabilitation and long-term practice. As adult learners, we're naturally much more sceptical, we're much less inquisitive, we're much more circumspect, we're much more aware and fearful of failure, which is important that we sort of think about those particular aspects. We generally want short-term episodes of learning. We don't want to learn generally for the long term as adults. We want to step into a learning situation, we want to get it done, and we want to exit often as quickly as we can. So again, that whole essence of practicing and doing long term for day after day, month after month, year after year, isn't what we tend to want to do as adults. We don't want the learning to go on all of the time. We generally want to learn through assimilation, which means that we're happy just to nudge away at the edges and just tweak things a little bit. We might change our hair colour, you might change your nails, you might do a little bit of this, change your clothes, etc., etc. Just nudge a little bit of who you are, but in essence you want to kind of stay the same and just tweak a little bit at the edges. We don't really want to learn through accommodation, which is where you throw everything up in the air and it comes down in a different way and you have to piece new schema together at that particular stage. As adults, that's not really what we want to do. And also as adults, what we tend to want to do is something called task-conscious learning, rather than what's called learning-conscious learning. And what we mean by that is imagine that you've just been given, or Christmas coming up, let's say, very generous partners, families, etc., and they give you some smart new phone or tablet or computer or whatever it is. Most of you will probably turn it on, try it out, learn the basic features that you need to have, and then stop at that point. Mostly nowadays, you don't look at instructions, you don't follow it through methodically at that stage, you just want to give it a try. And so that's generally what we want to do as adults, is just give things a try. That's probably different, and I'll talk about how that's a little bit different for patients who are actually quite frightened of trial and error learning. They're frightened of what the consequences might be because they're fearful and sceptical and they're afraid of failure. So actually a lot of them talk about not wanting to do trial and error learning. They're also not always so fond of trial and error learning because they see it as a waste of time. Why do trial and error? If you can just tell me what I have to do, I'd much rather do it rather than work it out for myself. So there's a sort of mixed feelings there, I think, when we're thinking about patients with learning. But these are some of the things that we can think about that are really quite characteristic of adult learners, all of which make the job of engaging in rehabilitation really hard to do. There are also some interesting aspects to do with relationships with adult learners as well. So there's a real difficulty of this sort of conflict is, are you an adult, are you a learner, are you a patient? And those three things can sit together, but they can actually sit and feel that there's quite a lot of lack of congruency between those particular aspects. And this idea of submitting to the unknown is, again, hard to do as an adult, particularly if you're having to do that to learn things that you achieved in childhood. So if you're learning to walk again, or toilet, or dress and things, and to submit to that unknown and engage with it isn't something which we would naturally do as adults, and that can be hard for adults to do, and trying to work out, as I say, am I an adult? Am I a learner? What am I trying to do? Am I a patient? How do I bring all those different aspects together? And what we see as a result of this is we get a lot of learning defences from the patients that we work with. And learning defences are very common. We go through life putting up as adults quite strong learning defences because we don't want to change. So we actually go through life trying to hold on to that stability. And so when we think about these passive learning defences, this is what we do all the way through life. And we often live in this sort of world of this kind of learning ambivalence where you both want to change and you don't want to change at the same time. And that's how many people live their lives. You kind of want to lose weight, but you don't want to lose weight. You want to be fitter, but you don't really want to be fitter. And sort of living in that kind of halfway sort of place. And that's where we are often as adults. But again, that makes it harder if we're trying to get people to engage in rehabilitation if they've got quite strong passive learning defences that are there, so they kind of want to but not enough to engage in tasks at those particular times. So some things that we can think about for adult learners. They're learning, as I say, at a point of life disjuncture. So we learn what we want to do is we want to live our lives at a point of harmony. That's when we can draw upon our past examples and the world makes sense. If you have a stroke or you've just been given a diagnosis of MS or Parkinson's or something like that, you potentially move into the position of life disjuncture, where everything that you could draw upon from before, everything you could trust and believe and made sense, no longer makes sense at that particular time. And that's a hard place to be at that point of disjuncture. And what it leaves people is in this really complex position where they want to learn because they want to get better, but they don't want to learn because they never wanted that condition in the first place. They never wanted the stroke or the MS or the Parkinson's or whatever it is. So they're caught in this really difficult position of, say, wanting and not wanting. So they say they're often having to learn rather than inherently wanting to learn. And that makes quite a big difference, again, when we're thinking about engagement with activity, of what that means. And so thinking about, say, how do we get people involved and engaged with this? They're then learning to an unknown future. And we have got one student in the room today, but the others aren't here. If I'm thinking about my students, short of saying to them, I will write your essay for you, or I will sit your exam for you, the next best thing that I can give to them is past examples of what essays or exams previously look like. That's what they want to see. What does it look like? What should I be aiming towards? What was a good essay? What's a failed essay? If you can give me those, and I can aim towards those at those times. It's incredibly hard to learn to an unknown. And that's what we're asking our patients to do. So they've got this conflict between the life that was before and the life that's in the future. They've got a very strong visibility of life before. That's what they know. That's what they've had for the last 50, 60, 70 years, whatever it is. They've got very little or no visibility of what that future is going to be like. So it's really hard to go to that. And learning is done in anticipation of what the future is going to look like. But how do you do that if you have no idea? And the example that I use here is the technical challenge of the Great British Bake Off. That middle challenge that they have there where they don't know what they're going to be baking. And in the first round, it's really easy because they're baking something like, I don't know, it's not easy because I don't do baking, but, you know, it's relatively easy because they're baking something they've seen before, like a custard cream or a treacle tart or whatever it is. By the time they get to the final and they're baking a chocolate burger, schmorger, warger, whatever it's called, and they're like, is it high? Is it low? Is it round? Is it square? Is it a triangle? I've got no idea. And you'll see them all busy looking around the tent, see what are other people doing at that stage. It's really difficult to learn towards something that you don't know what it is that you're going towards. And these are the types of questions that your patients might be asking, is what am I meant to be aiming at? Have I learned enough? Am I learning what I ought to be learning at those particular times? Am I closer to my goal at this particular stage? Because you don't really know what your goal is. You don't know what your future is. You don't know what it's going to look like. When do you stop? When do you change? Are you doing enough of it? Should you be doing something different? All of that is really hard for patients. And there's a little quote that comes from a very different world of actually American civil rights, but I think it really relates to our patients, is you cannot be what you cannot see. And our patients often struggle to see what it is that their future is going to be, which makes learning, again, and engaging in rehabilitation a really tricky thing to do. We think about the early stage of stroke. This is what patients want to do. So their visibility at that stage is they want to enter the learning, they want to get it done, and they want to exit. And that's what they're anticipating being able to do, because they haven't necessarily got any concept that this is going to be a long-term thing forever for the future, and that's what life is going to be. They sort of think, yeah, I've had a stroke, and then this is what I need to do, and then I can exit, and life will be better at that particular point. They've got very little awareness at that early stage about any sort of personal or cultural learning, because they don't anticipate being in this stroke system world for a long time at all. And so just thinking about what are they looking for, what are they expecting at those stages in their rehabilitation. And then they're novices and they're newcomers. And some of you might have done this in days of old. Dreyfus's models of learning and the different stages of learning. So these are some of the things, words that you might be familiar with in the past. But these are often, as I say, novice learners. Even if they're quite expert patients in their conditions, they might well be novices at that particular time. So they've got little or no experience. They want to adhere to the rules. They're fairly limited, fairly inflexible in how they're doing things. So that's what we want to have in mind as these new learners into this new learning situation. So how do new learners come to us? Well, they don't come to us with a completely absent background. They come to us with a backdrop of existing knowledge. They've got some half-formed ideas, some conceptions and some misconceptions. So they come with something. So that word stroke, if that's what happened, or MS or Parkinson's, they're drawing upon something at that particular time. And here's a quote here back from the 1960s from an educational psychologist, and he said the single most important factor when we're thinking about learning is to understand what the learner knows already. He said, ascertain this and teach him accordingly. So really understanding what our patients are starting with is important for where they're then going to go in the future. So we're going to have a look at that, and we're going to work our way quickly through this particular framework and sort of hopefully help make sense of where our patients are at. And we're going to start in the top corner there of the knowns and unknowns. So if we're thinking about what is our patients are coming to us with, if we're trying to establish what do they know already and then building on that, we can sort of think about what do they come to us with. And we can think about that in relation to what do they know about their pathology itself, so what do they know about stroke, if that's a condition that you're working with. What do they know about recovery or improvement or maintenance, depending on what it is your goals are with your patients? And what do they know about the concept of rehabilitation? So what are they coming with at that time that you might be building on as part of your rehabilitation? So this was when I was speaking to a patient and I asked my patients, what do you understand about stroke? This is what Martin, they're all pseudonyms, said about stroke. Now he interestingly worked on the periphery field of medicine, so he had some medical training and background, and this was his interpretation 6 weeks after his stroke about what he thought had happened. So he talked a bit about having a clot, and then he wasn't quite sure, and he said perhaps the clot can be at the heart, going to the heart. Can it be after the heart? Wasn't quite sure, and he said worst place it goes to the brain, so perhaps that's where it occurred. So wasn't really certain. Then he talked about perhaps he'd had a bleed in the brain, so we're going between clots and bleeds and heart and brain, and not really certain about any of it at all. And if we look at the last line, which I absolutely love, he said here, predominantly in your left, it doesn't matter if you're left or right-handed, it will always go to your left, won't it? It's like, where does that come from? And this is someone who works in the periphery of the medical field, so had some knowledge, worked with people with stroke, he'd been there for about 6 weeks, had quite a lot of contact, and that was his interpretation of what stroke was. So really thinking about for your patients is to think, what are their knowns and unknowns? If you actually ask them about what their condition is, what would they say at that particular stage? Could they actually tell you much? Did some research years ago with people with MS, and I said something about the brain and spinal cord, and I was working with a chap who had really quite advanced primary progressive MS. He said to me, why would that be relevant to me, my brain and spinal cord? I was like, really? And he had no notion that that was relevant to him with his primary progressive MS, with really quite an advanced presentation. So spending a little bit of time to start seeing what your patients know about their condition will potentially give quite nice insights into your sort of starting point of that. This was Liz, who also, when I didn't know whether she'd had a clot or a bleed, she had her stroke secondary to endocarditis, so it had a lot of time in the acute setting and cardiology wards. And this was asking about recovery, and she ended this by saying here she doesn't really know what recovery is, talks about things being gone forever, have to relearn pathways. And I think if we speak to patients, they'll often say things like pathways and connections and learning, laying down new, say elements and those kind of things. They'll talk about that, and they'll often will use analogies of motorways and, cars travelling around systems and towns and all this kind of stuff. And so they've got these words. But actually, if you really deep with patients and say, what do you think really impacts on recovery? These are the things that they'll really think impacts on recovery, because this is what has impacted on recovery from anything else they've had in life up until that point. So you sleep and you rest, and that will help with recovery. You eat the right things and you drink a little bit, and that will be important to you. If you take your tablets and your medication, if you do a bit of gentle exercise and you give it time, you'll get better. And that's what most people will associate with recovery. So even though on the one hand they'll be saying pathways and connections and et cetera, deep down, these are the things that most people will associate with recovering. And all those things are true if you're recovering from stroke, trying to get better from stroke. But we're then saying to them, but you need to exercise, X number of times a day. You need to engage. You need to do high volume. You need to do repetitions, etc., etc., etc. And somewhere in the back of their mind, and actually quite a big place in the back of their mind, these kind of things will be predominant at that stage. Because even if they've had, big things before, cancer, etc., etc., these are the things that they did to help recover from those, from surgeries, from things. And what we're saying is actually something very different that's going to sit differently from them. That's their building point. So they'll look at you and they'll smile and they'll nod nicely and they'll talk about pathways, but this is what they'll believe deeply inside actually about what recovery is, particularly in the early stages, on their sort of novice learning stage at that time. And if you ask them what rehab is, most people have got no idea at all what rehab is. They might have seen a physio in the past. That's where your physios are lucky because they've got some context, OTs, speech and language, anything like that, no idea at all. But the whole concept that there would be something that would help you get better is actually quite alien to people as well. So that's their starting point. So they're knowns where they had a stroke, they knew what their future was going to be like until they had their stroke, but they have a lot of unknowns as well, at particularly those early stages. So unknown really about what stroke was in any detail, unknown about recovery, unknown about rehabilitation, and unknown about their future lives and what it's going to look like. So that's your starting point often with patients that you're working with. And what we can do with that, if we establish those things with our patients, we can think about what are their conceptions, so what of all of that have they got broadly correct, but what are their misconceptions, what are the things that perhaps are what things that we could work on if we're understanding what their thinking is at that time and what are some of their misconceptions. And these are important to know because that's what your patients are going to build on to try and make sense of, and their family members, to try and make sense of what's happening at that particular stage. And from those conceptions and misconceptions, they'll then develop some beliefs and some expectations and some wants and some hopes for the current time and for the future as well. So the beliefs that the patients had, so when I spoke to them and sort of said about weakness, they didn't all know that the weakness actually came from stroke. Some of them thought that because they'd been in the acute setting for a while and not done much rehab, the weakness came from that. Some of them thought the weakness came from things like arthritis, which they lived with as well. So they didn't necessarily associate weakness with the stroke itself. They kind of had mixed beliefs about what their future was going to look like, and a number of them had that sort of still saying, not really certain, but that sort of thinking that they'd get that light bulb moment and everything would be better at that particular point. And they had beliefs that they needed to do physiotherapy, they needed to do exercise, and it needed to be in a systematic way. So those were some of their beliefs that they held in relation to what they knew. And from that, they had some really clear expectations and wants of what they were then looking for. So if you just think to yourself for a minute, if you were in a new learning situation, if you were joining that choir or that gym or the pottery class or whatever, what would you expect or want to be in place to help you learn? And what would you not expect and not want? So you can just ponder for a minute about what those would be. So you're putting yourself in a new learning situation, or your child was going to take driving lessons or whatever it was at that time, what would you be looking for? Because this is what our patients are looking for. So they very clearly expected that effort put in would equate to output out at the end, because that's up to that point what learning has generally been about. You work harder, you do better as a result. And that is a big issue which really comes back to haunt patients later on. We'll talk about it in the home situation, about that's really hard for patients to unpick that understanding that effort in doesn't equate to output out if you're recovering or trying to, from stroke, TBI, whatever it is at that stage. They then expected to be helped with staff who had greater expertise than they had, which is quite a normal expectation. They expected it to be provided in a regular, systematic way, and they expect it to continue until they're better, which are all completely normal expectations for a new or novice or any learner at that stage. So our model that we're offering to patients, which is the model that we can only offer in the current situation and where we're at the moment, sits completely contrary to any other type of learning situation. What they're not expecting is to be given a sheet of exercises and say, go away, do it yourself. Just in the same way that if you were going off and your child was taking driving lessons, you wouldn't expect them to have 2 sessions with the driving instructor and the driving instructor say, here's a leaflet, we're never going to change it, teach yourself how to drive and see how you get on. You know, it's just not what we do if we're in a learning situation, but it's what we do in our rehab type settings that we have. And it sits very contrary to what people are looking for and expecting in that kind of learning situation. So, from those expectations, a patient has got what's called a desired curriculum. They're looking for something very particular to be delivered. So based on, let's say, those knowns and unknowns, the conceptions and misconceptions, they're looking to see something that's there. And that's important to understand what they're looking for at that particular time. And looking is a very active process. We don't passively scan the world. We look actively at the world. So it's really helpful to ask yourself, and in your teams, with your interaction with your patients, what are they looking for at that particular time? Because what they look for is going to be what they then see or don't see, and they're going to miss anything that you're offering but they're not looking for at that particular time. So understanding what people are looking for is really important for sort of thinking about what they're interpreting or not of your particular service. So, what are patients looking for in the early stages of stroke? It's very, very straightforward. It doesn't matter what's wrong with your patient, whether it is weakness, whether it's more of a sensory deficit, whether it's more of a sort of apraxic, dyspraxic presentation. If part of your body doesn't work, really the only thing that patients will then associate with that is I can't move that limb as I want to because it's weak. Because all those other things are quite subtle to understand. If you're weak, you want to be stronger. If you want to be stronger, you need to do some exercise. If you need to do exercise, you need to see a physio and you need to go to the gym. That's all people are looking for in the early stages after stroke. That's their understanding, that's how they make sense of it, and that's what they're looking for. Which means that they'll see all the physios in the room and they'll miss almost everything else. And say, well, we'll show that in a couple of quotes and things that we've got. So it's very simple how they're making sense of it, but this is sense making for people in stroke. So that's your patients. On the other side of the framework, we've got what we're delivering. So we've got our planned curriculum of rehabilitation, of which some of it we deliver. So we've got those kind of methods. And what was really important is how do those things come together in the middle? Have we got alignment between those different aspects? Are we delivering roughly what the patients are looking for or not? So what's visible and invisible in a stroke situation? So here was our boundary that we wanted our patient to cross into supported rehabilitation. Here is what rehabilitation is. So like formal education, it's assisted or purposeful learning. It's been designed by us to help the patients learn. It's educative learning rather than just learning from experience. That's what rehab is, and that's what our patients are looking for, something provided in a structured and systematic way that will help them learn and will help them to get better. So keep in mind that's what they're looking for, because we take ourselves to the acute setting. So where I was doing my work, the acute setting was a very standard district general hospital in the country, and patients were there probably meant to originally when life was designed for a few days. In reality, they were often there 5, 6, 7 weeks before the bed on the rehab unit became available. So what was visible to them in the acute setting was it was noisy and it was busy and the people were unwell. Fair enough, they were quite happy with that. You know, they understood that that was there. The people were kind, weren't really sure they knew their name, they were very transient, but again, they could put up with that, they weren't expecting anything particularly different. What was invisible to them, though, because in this acute setting they had very few therapy staff, was that the people in the acute setting got almost no therapy input at all. So it was very definitely a place of what they felt was this passivity. They weren't up and out of bed, and many of them didn't even have a chair by their bed that they were got up into at that particular stage. There was no structured therapy at that time. It was very ad hoc. They might see somebody, they might not. And what they talked about was that for every new patient they could see coming onto the ward, they knew they were falling down the list of likely of being seen at that particular stage. And this was hugely disturbing for the patients. So we had this massive mismatch between what they were looking for and what was being delivered at that particular time. And it was really, really profound for the patients in a way that I had no anticipation it was going to be this profound for the patients. It really very significantly distressed them. And out of my 14 patients that I had these long-term interviews with, 3 of them talked quite openly about suicidal ideation in those 5 or 6 weeks on the acute setting of not getting the rehab that they were looking for at that stage. Because that rehab that they were looking for was really important to them, and they weren't getting it. So we had this huge mismatch between those 2 different aspects. And this was one of my participants talked about this sort of, ability, this sort of feeling of wanting to pack up and how easy it would be to pack up at that stage of not getting the rehab at those particular stages. So it was really, really profound. So the acute setting itself was unpredictable and unknown. Therapy interventions were largely invisible, and therefore their sense of hope of recovery was invisible as well. Because as far as they were concerned, the therapy was going to be their recovery. They were weak, they wanted to get stronger, they wanted to do their exercise. That wasn't happening. Therefore, there was nothing visible to help them think that they were going to get better at that stage. They desperately wanted to step over that boundary and supported rehab, but it wasn't there. It wasn't visible for them at that stage, and that was really profound for them of not being able to do that. What they were experiencing made no sense at all for them because it was so different from what they were looking for at that time. It was really profoundly disinvitational, and it didn't feel safe. And feeling safe is really important for patients, really important for learning, is what does it mean to feel safe in a rehab environment. So if any of you do work in the acute setting, I know these people the therapists would have absolutely loved to have given more. It's nothing against the therapists there. They just didn't have enough staff. That's what was offered at that stage. But it had a really profound effect. It had a profound effect at that stage, and it had a really profound effect later on when patients went home, and the therapy was also more limited at home. And having had this very profound sense of being abandoned early, made the sense of abandonment later on even more profound because they'd been there once and they felt they were back there again, and that was really hard for them to cope with. So really big, an effect that I never anticipated they were talking about in that acute setting. The rehab unit, on the other hand, was all singing, all dancing, absolutely fantastic for them. They loved it, the place was lovely, the people were lovely, they adored the place, and really importantly, visible to them was they had a really clear planned curriculum of activity. And I cannot stress how important the single most important thing for the patients was in the rehab unit was their timetable. One scrappy bit of paper that was on the wall in their room was the single most important thing that the patients had in the rehab unit. They were given it by the staff because the staff thought, they could help them organise their day, they would help them be more proactive, they could be planned, they could be in their therapy sessions when they wanted to. Patients weren't interested in any of that. The reason they loved their timetable, it was a very visible sign that someone was going to help them to get better. So it gave them a really profound sense that someone is going to come each day this week and I have a chance of getting better. It went up on the first day they arrived, and it was really, really important to them. So if any of you work in units where you're thinking, in this actual unit, we're thinking of getting rid of the timetable because did it make the patients too dependent? It was like, no, keep that one bit of paper because it's really profound for your patients, of that sense of hope that it gave at that time. So it made complete sense. They felt safe, they could trust and they could believe it. It was really profoundly invitational, mostly. Okay, not quite as easy as that. Because what was visible was the therapy gym. What wasn't visible to them was anything that they did outside of the therapy gym impacting on their recovery. I seem to have lost it. Oh, there we go. And this was important. So when I said to the patients, you know that time you spend on the ward, all the rest of the day when you're not in the therapy gym, is there anything that you do here that you think is helpful for your recovery? The answer was a big, profound no. There was nothing that they associated except for learning a little bit about a new routine, about what they were doing on the ward that was helpful for their recovery. And so when I said to them, you know that washing and dressing practice, you know the food, you know when you go to meals, you know the walking up and down the corridor, any of those type of bits, do you think that impacts on recovery? They had no association of those things impacting on their recovery at all. And And I said particularly about the washing and dressing practice, why do you think you do it? The response at that stage was, it's really important that I'm washed and dressed and I smell nice, because wouldn't it be bad for the physios if I went to the physio gym and I was smelling? And that's what they said to me. It was so profoundly shaped towards physio. And I was reflecting on that. And again, it's one of those things, you think, actually it's not rocket science at all. When you wash and dress in the morning, you're not doing this and thinking to yourself, I'm updating my motor programs each time you do that. You're doing that to get washed, to get dressed, to get clean, to present yourself to the world. And somehow we're expecting our patient to switch overnight a mentality of thinking that actually that's about recovery and motor programs and learning, etc., etc. They've got no concept of that. Washing and dressing is to get clean, because that's what you do. Eating is about being full. It's not about, as I say, doing that upper limb practice and things. So they're not making that link. They're not looking for it, and therefore they're not seeing it at that particular time. It doesn't make sense to them, and therefore they're not seeing it. And even if we break down the therapy sessions, there was still a mismatch. So we have a difference between how they interpreted the lower limb sessions, and this is where it's going to get particularly tough listening for the occupational therapy colleagues in the room, so swallow hard, dig deep. Here we go. So their lower limb sessions made sense. So as we know, recovering walking is recovering overall for many of the patients that we work with. So they had this deep sense of lower limb recovery and getting better. The lower limb sessions most visibly led to the desired outcome that they wanted. So they made complete sense. The lower limb sessions often had a really profound moment of, this is the first time they've walked, everyone wept, it was recorded and WhatsApped and sent on video all over the world to their relatives, etc., etc. So they had this really profound moment of the really positive feedback. And broadly speaking, each lower limb related session that they went to, they got a bit better. So recovery was happening in the right direction. Upper limb sessions, in contrast to that, were more tricky for them to interpret. So they had less awareness, at least early on, of upper limb being a desired outcome. We know that from many of our patients. The participants followed a fairly traditional pattern of upper limb being less functionally recovering than the lower limb, and we know that that's relative, that you can have a pretty poorly recovered lower limb, but it's functional in the same way that you don't have for an upper limb. So they followed a fairly traditional pattern of lower limb getting better and enabling them to take a few steps, and the upper limb being less functionally useful. Importantly, the treatment didn't look like doing exercises that felt like strengthening. So here's a quote from one of the patients. So I said to them, do you see the OT? Do you do any of the practice that the OT has given you? And the patient, Tony, and it was him and his wife, talked about this. Oh, she's the one that has the balls, not the balls backwards and forwards, the towel and dominoes, and that's what they were associating with the OT sessions. I said, would you ever do any of this type of exercise by yourself? And the patient said, no, they're too menial. They're not the sorts of things that you'd get up and you'd do by yourself. I said, have they given you any exercise to do on the ward? The patient said no, and his wife said the putty. So to which the patient said, oh, I've got the putty, terrible thing. The wife said, it's no good saying that, that is your exercises. And the patient said, it's not what I call exercise at all. Now, actually, this patient had really quite a marked selective motor control issue, but didn't have any weakness. So the putty and other tasks like that was absolutely the right thing that he should have been doing. It wasn't like it was just random putty given out to him. It was absolutely the right type of exercise. But as far as he was concerned, it didn't look like the type of strengthening exercise that he was looking for, and therefore was never going to be an exercise he was going to practice by himself. So thinking about what we're giving, what they're looking for, what they're receiving, how they're interpreting, is going to be really important for thinking about their long-term engagement and stepping over that boundary into self-supported practice. If it doesn't have any resonance to them, they're never going to practice it again. They're going to smile and nod and tell you how lovely you are. You're going to leave the room and they're never going to do it. So really thinking about what this means to patients is important to sort of thinking about, say, if we're wanting self-supported practice, this is going to be really important for them to do. So, with the upper limb sessions, there often wasn't any positive emotional moments related to the upper limb. They got very, very few of those. And what also happened is actually lots of the sessions got to a stage where they weren't making progress, so it actually became quite negative, and they got quite a lot of negative feedback at that stage from the upper limb sessions. And there's only so long that you'll keep going in the face of lots of negative feedback, and that was difficult for them. Lower limb sessions as well was more like learning through assimilation. So again, the lower limb, they could just nudge away at the edges at that time, and it sort of got better enough just with a little bit of nudging. Whereas the upper limb, often what they were being able to having to ask to do was learn through accommodation, of actually getting this concept. This arm is going to be different from how it was before, might be profoundly different from how it was before. That learning where you throw it up in the air and you come down and have to have a new schema as yourself as someone who's got an upper limb that isn't recovered is a whole heap of learning that your patients never want to do. It's emotionally really demanding. It's sort of hard for people to do. It's not wanted, etc., etc. So that's a lot of difference there between lower limb and upper limb at that time. So how patients made sense of this was the lower limb sessions, input in led to outcome out. Broadly, each time they went, they got a bit better, and that made sense. For the upper limb sessions, input in didn't lead to the desired outcome out, and they were starting to get that first realisation that they could work hard and they weren't necessarily going to get the output that they wanted. How they made sense of this was by saying this. The physios were doing something very right because the lower leg was getting better. The OTs, who are more predominantly upper limb focused, were clearly not doing the right thing because their upper limb wasn't recovering. And that's how they interpreted what was happening as far as their recovery was concerned. One group of people knew what they were doing, the other group of people didn't know what they were doing. And in their sense-making, because they had no concept that upper limb recovers different from lower limb, that the upper limb is more complex, all of those kind of things that we would understand as therapists, patients don't have that knowledge. So this is how they made their sense-making at that stage. The physios, as I say, profoundly invitational, and they said to me then at the end, I now want physio on my arm. Because they'd made the link between physio, lower limb getting better, and they'd lost the faith in what they were having for their upper limb, and that was really difficult for them at that stage. So this was not, the physios weren't doing anything fantastic. They were all lovely, they were doing fantastic things, but they weren't by rights doing anything more fantastic than the OTs. But in the sense-making that patients do based on how they interpret stroke, this is how they came to unpick it all at the end. And you say that then makes it really difficult, makes it really hard as well for patients who then discharged home, mobile. Physio is stopped, the person who carries on is the OT, and they've lost the faith in those individuals. So just thinking through and why the OT job is then so hard of what's come before at those particular stages. So I say it's nothing about what anyone's doing, it's purely in the sense-making that people do. So this really has an effect. It has an effect on people's well-being, and it has a really big effect on what they do or don't do at the end of it. So trying to unpick all these elements is important to sort of help us make sense of this. So what we're looking for is something visible and invitational. It's a place that's kind, that's trusted, wanted to believe. It needs to make sense. They need to feel safe. That's what people are looking for in a supported rehab environment. Just very quickly, because I'm aware of the time, just a few thoughts about self-supported practice. It might be either in the gym or at home, in the ward or at home. So we know, as we said, that we want people to engage. We know that people don't engage, don't do the intensity that we're after, but this isn't unique. So we know that somewhere between 50 to 70% of all healthcare advice isn't followed. Huge amount. Think about how much of healthcare is wasted from this, and that could be medication taking, all sorts of things, dietary advice, etc., etc. So getting people to engage and follow healthcare advice is incredibly difficult to do. It's a very difficult task. And then we've got these extra challenges. And my thoughts is how much of it is wasted in this way because we haven't really made these links between actually how people learn, what they're learning, what they're thinking to engage with activity. So this was the rehab unit that I was on, an NHS rehab unit. Yours may or may not look like that. It was beautiful. There was so much to do. We can't really see it in this diagram of the day room, but there was a piano, there was an exercise bike, there was Wii Fit, there were computers, there was everything, there was a sensory garden, there was absolutely everything. And the patients spent their entire day in their room by their beds. And they weren't there in doing any of the things because it comes down to what they're looking for. They're only looking for the physio gym at that stage. If you said to any of you who've got children at school, if you said to your children, what learning did you do today? They would they would probably associate learning, classroom, history, maths, geography. They're not going to say, I did profound learning in the canteen at lunchtime. I did really big important learning in the loos. They will have done lots of learning in those places, and actually much more important learning, but they're not seeing it. They just associate learning with class and with lessons, etc., etc. But actually learning happens everywhere, but it's what's visible to your patients or not at that particular stage. So as I say, what is visible, what's invitational? If we want people to step into a supported exercise space, how do we help people step into those spaces at that stage? Really important to keep these in mind. This stepping into the unknown, highs and lows, is really important that we think about. Your patients are having to do this when they don't necessarily want to do it. For those who've got residual deficits, there's no clear sign of when they can stop. So what's that point when it ends at that particular stage? And they've got to have some kind of belief that there's going to be some type of positive thing at the end of it. So we know that there's a really strong link between learning content and the emotional aspect of learning. If things are going well, your emotional well-being is really high. As soon as things stop going well from the content learning, your emotional well-being goes down really profoundly with that. So, if you had to ask your patients to describe their independent practice, what words do you think they would use? Anyone want to suggest any words that your patient might say about their independent, self-supported practice? Useless, yeah. Boring, yeah. Mindless. Yeah, mindless, repetitive, etc., etc. So here was this patient, Paul, talked about it being soul-destroying. Who's going to do exercise that's soul-destroying? No one's going to do that. But that's somehow what we're anticipating and expecting our patients to be able to do. It's really hard to say as adults it's not what you want to do this long term. You've all just said those words: boring, mindless, repetitive, tedious, whatever it might be. This is not what our patients want to be doing at that stage. So it's a massive ask to step into this space for them at that particular time, to really think about, say, what it is that we're asking people to do, both for that initial engagement and long-term adherence. So if we want people to adhere, and we talk a lot about adherence, we need to first get them to engage, we need to get them to learn, and therefore we really need to think about teaching. How do we teach our people? What do we actually do to help people step into that particular space? We tend to think about, if we do the supported rehabilitation, our patients will automatically know what self-supported practice to do. Nonsense, okay? How many children go home from school and think to themselves, oh, that stuff we did in history today, that was probably meant to be my homework tonight. You know, they don't do that, just in the same way that adults don't do that either. They don't sort of think, oh, I was practicing that, perhaps I should practice that myself. A few do, want to do, but largely if we keep in mind the fact that, say, that adults are sceptical, they're fearful, they don't want to get it wrong, thinking about how we teach is really, really important. So we could definitely think about, do our patients know that they're actually receiving education at that time? If we wrap everything up into treatment, is it clear to them what they are getting in the way of education? If we want them to learn something, how clear do we make it? Particularly in neuro rehab, where patients might have cognitive limitations, might have speech limitations, perhaps their family members aren't coming in and seeing them in their therapy sessions, and the family members come in the evenings and desperately want to help them, but got no idea what we want to do. This rehab unit I was in was lovely, they were fantastic, but they very rarely wrote anything down or gave any kind of video, did anything to really make overt what the learning was at that particular time. So really thinking about how do we teach best to really help people learn is important. So how do people know, say, how to teach based on how people learn? So definitely thinking about that kind of relationship. I'm going to show you a really busy slide, which we won't linger on. But there are two different sort of camps when we're thinking about learning. One is really our concept of the enriched environment, the behaviouralism, where what you do is you basically set up the environment and expose people to it, and they'll learn through that exposure. And that's great, and that's what they wanted in the early stages of rehab in the stroke unit. And many people in healthcare do fine with that type of approach. You know, someone on a ward just needs to get their mobility a bit better, just give them enough exposure, walk them up and down enough, they get better enough, they can go home. But for people with ongoing deficit, that's not going to be enough. We need to be really thinking about a much more overt, and this is where we really understand our patients as learners, and actually what is it, what is the learning, what is our patient able to do? If we want someone to know what to do at home, we really need to help them, teach them, so they know what they're doing at that stage. When I spoke to the patients at home, they knew what they could do with their lower limb, because in essence you just need to walk. But the upper limb, they had no idea at all what to do. They went home with no idea what to practice at that stage. And they couldn't work it out. They did a little bit of what they'd done in the hospital, then they tried a few weights, then nothing worked, and then they stopped at that stage. So really thinking about that sort of aspect of that teaching and learning. So the rehab unit was really inviting, it was really visible, but they did very little to help people get ready to go home and have that learning in place and readiness for what the person was going to do when they get home. And it's not enough to say the community team will go in and do it, because the community team also don't have the time to invite people into that self-supported place. If you want to get them to cross that border, you've got to make it really visible, and you've got to help invite them into that particular space. It's not a boundary that they'll step over themselves, from will. They don't want to be there. We've got to help them get there at that time. So there was lots at the rehab unit that was really positive for them. Really importantly, they linked their progress to therapy, which then was problematic when they went home, and the number of community sessions were reduced, very sort of dependent on that sort of thought that was what was making them better at that stage. So home, very quickly, they lost belief and they lost trust that home was going to be a good place to recover at that time. Exercising at home, as we said, was often very demotivational, disinvitational, and it meant that emotionally it was really hard for them. So when I said to them what would make a difference, what they wanted more than anything else was to be able to come back to the rehab unit where they had their therapy, because that was the last place that they'd had any positive feedback about change and improvement. And they were desperate to get that sense of improvement once again. And they linked the place to feeling better, making an improvement, and they really, really wanted very profoundly to feel that sense of improvement again at that stage. So this was what they thought was going to happen. So they'd come massively downhill from the acute setting. They'd gone massively uphill in the rehab unit. They thought that was going to continue, and actually in reality it looked a little bit more like this when they got home. And for the ones that then go downhill, it was particularly profound because, as I said, they'd been there once before and they found themselves back in that place again. They were really, really anxious in the acute setting that they were going to have to work out for themselves how to get themselves better. And that same anxiety revisited them when they got home, that it was then up to them for the future to work out how they were going to improve. And they say they'd been there once, being there again made it particularly impactful for them at that time. So home is hard. Home is a place for real important personal learning for patients. So learning the exercises sits alongside a whole heap of other learning that your patient's having to do that they had no anticipation that they'd ever have to do at all. So somehow that exercise learning needs to sit alongside a whole load of other types of learning as well. It was also a place where that aspect between input in and output out was most profound. So here are a couple of quotes from patients. I thought I might get it back. Lots of people said you're doing so well, this and that. And they said it's just not coming. This was a patient who said to me, if one more person tells me I've recovered well, I think I'm going to shoot them. Because he'd done really well with his lower limb, and his upper limb he had a really profound sensory deficit, so he couldn't use it. And he looked great, except he couldn't return to any of the functional things he was doing before. And it really, really bothered him at that stage. This other one here, they say the first 6 months we're going to make the most recovery, and they said it's just not happening. And that real sense of, I try, and I'm not getting better. And that was really profound for patients to get to that point of realisation that it wasn't going to happen. Also a point at home when we had this aspect of self-blame. This was a particular patient who, again, had done a really nice recovery for his lower limb. Upper limb hadn't been so well recovered. And his sense-making of that in the long term was, when the therapist asked me in the early stages what goals I wanted to have, I told them I wanted to walk. I didn't set an upper limb goal. The reason I haven't recovered, my arm hasn't recovered, was because I didn't ask them to focus on it, and therefore it hasn't got better. If I'd asked for an upper limb goal, they would have given it to me and my arm would have got better. So it's my fault for not asking that my arm hasn't got better. And that's what he lived with every day, that sense making of why his arm hadn't recovered, because he hadn't asked for that goal at that stage. So really profound to sort of think about, that's to say his sense making and recovery over time. And say, it's often, I say, they need to find that safe position of defeat if that's what's going to happen. And that's really hard for people to do in that home situation. So we need to think about the learning environments for patients. We need to think about environments where they can feel safe, and hopefully they can then thrive. It's really hard to learn in a learning environment where people don't feel safe, where they feel anxious and they're not enabled to learn. And home is often that position. And for some people, the acute setting is that position for patients as well at that particular stage. They can afford to feel a bit vulnerable, but they want to be supported with that vulnerability at that particular time. So we need to think about people, we need to think about place, and we need to think about, hopefully, that visibility with the patients, that what they're receiving is doing the right things at that particular time. Somehow that desired curriculum matching that planned curriculum so that things come together for our patients. And so hopefully we can make that framework work right for them at that stage, till we can enable them to succeed and thrive, hopefully, if we can make that work and we can get that desired curriculum matching the received curriculum for our patients. We'll bypass that one. So hopefully we've thought a bit today about supported rehabilitation, a little bit about self-supported practice. It's a whistle-stop tour. I'm just looking at the clock, very aware of that. So we'll call it a day. There's my email address, should anybody want to get in touch. And hopefully it's given you a bit of a flavour.
Thank you, Sally. That was absolutely brilliant. I'm sure there must be some questions. As Nicola says, you're not allowed wine until you've asked a question. Go on, Will.
Sally, thank you for that talk. It was fantastic. I remember seeing you speak a couple of years ago on the stroke forum, and it's amazing to see how much further you sort of develop this concept. My question is, are we the right people to be teaching what we're trying to deliver? We are expecting people to be learning at a certain level. We're probably quite a biased group in terms of we are constantly learning within our roles. That's part of what we do. A lot of our patients will have finished education 50 years ago and have not maintained that ability to learn anyway. Are we the right people to be teaching?
Yeah, I mean, I think about that a lot, and particularly say researchers. And I think when we look at who would take part in research trials and bits and pieces, we've got about that 30% of the population who I think are life learners, and we'll all be able to have those people in mind, people who go through life. And the analogy, I'm probably a rubbish analogy, but the analogy I often used of those people: if your boiler breaks down, most of us will call up the plumbers and say, "This is my budget, fix it." There'll be a small number of people that will research on the internet, will look at boilers, will decide which boiler they want, and will call up the plumber and say, I want the Valent 365, whatever it is at that stage. Most people just want to dispose, to pass on that to other people. And that's, same thing, a car, whatever it is. We don't say, most people with adults, they just want to live life. So we're asking people to do something that's really fundamentally very different from how they want to spend their days. And you're absolutely right, as people that work in the field, we have that potential mismatch because, again, we've done our education, we've done learning, particularly those of you in the research field and things like that, and so thinking about say what that communication is like. I think, to me, I suppose the sort of key take home as I got with this, I remember very profoundly when I did my very first early work, which was a qualitative review. To this day, I sort of picture myself in the library where I was sitting when I had that moment of realisation that this is about teaching and learning. And I'd never really thought about it. I mean, I've been an educator for years. I was very aware of kind of what we did in education to extend the classroom, and I was thinking, our patients don't get this. But I'd never really thought about us and patients as teachers and learners. And I just that sort of thinking, even if we just got that sort of change of thinking a little bit about, I am a teacher at this stage, this is a person who's learning, and just thinking about some of those practices and bits and pieces. I think we can do it, we have to do it. It's a job that we do, but I think even if it's just thinking in that slightly different way, and certainly when I was going through my work as part of this, every bit of work that I read in educational theory, every single bit without exception, I would read and think, that's my patients, that relates, that relates, that relates. So I think we've got an awful lot that we can take from learning and educational theory and apply it and think about it with patients and sort of think about that, can it help us understand it better? So I think you're absolutely right, and it's something I've thought about a lot. Are we the best? How does it, and say particularly, for those who've, done an awful lot, how does that sit with patients who, as you say, just live life? And that's where patients are. So I think as much as anything, what I'm hoping, there's no easy answer to this, because that's often the question, where do we go next? What's the answer? Even if it just takes away some of the blame. Because I think we blame ourselves, we blame our patients, for not doing, and even if it just helps change that way of thinking to actually understanding how difficult it is and things, and why, and so that sort of thing about thinking, for many of us, if we engage in exercise, we do it with others. Most of us don't do it by ourselves. Most of us don't do exercise at home by ourselves, and that's sort of thinking about, do we just change our thinking about what we're expecting to then sort of think, actually, let's think about this like learning in other ways, and actually does that shift some of how we approach this? But certainly from a perspective of, if we take learning, no one would design rehab as it is if one was really thinking about learning. I mean, it makes absolutely no sense at all, which is why we largely fail. Patients do get better, but we don't perhaps get them as better, or they don't get as better as they perhaps could do.
Any other
I think
questions?
we've got a question over there.
Yeah, over there.
Yeah, so you hinted then at peer-to-peer support afterwards. Did any of that come out of your research?
Not particularly, because of the unit I was in didn't really have that. They talked a lot about the other people, particularly in the inpatient setting, the other people that were on the unit at the same time as them. Sometimes people happened upon other quite similar people and would spend time with them, others they wouldn't. I had a couple of people that were in and around the age of 50 as part of my research, one who was sort of 49, one who was in his early 50s when he'd had a stroke, both of them gentlemen, and both were on the unit with much older people, and then found that really hard and therefore spent time in their rooms and things. So there wasn't on that unit a particular peer-to-peer, aspect in a formal way. If the other people on the unit at the same time were right, they enjoyed spending time with them, but it wasn't something that was formally done, so it wasn't something that particularly commented on. But that
group therapy sessions going on?
Yeah, there were group sessions, yeah, which worked for some and didn't work for others. So it was an upper limb group, and I would say it worked well for the more cognitively impaired individuals and worked less well for the people that had the very, I'm weak, I want to get stronger, I want to get better, just because of the nature of how that upper limb group was organised and how it ran. It was a lovely group, but it worked for some and it very definitely didn't work for others at that stage. So, but I think the visibility is hard as an aspect. And even seeing, what does seeing actually look like, even if you're with other people who might be further on than you or not. But yeah, it was interesting.
Any other questions?
I've just got one question. Excellent. And also I was thinking a lot about patient therapy and the level 1 unit particularly. And I just might, when you're observing the OTs doing kind of more of the ADL practice, did anybody actually reflect and look at different ways of trying to explain occupational therapy? Because it is a challenge. And I was thinking about our timetables on a level 1 unit, which is back to back. So I wonder whether we run in, we wash and dress, then we move on to the next one. There's not that time for reflection to help somebody have that learning about why we're there. What are we actually working on? How do we reflect on your learning? Do we do that visually? Do we do that by looking at pictures? Do we help you to learn to be able to be more independent when you get home? Basically, it just changed the whole way we're going to work. Right? It's interesting, isn't it?
It is, yeah.
People they're thinking, oh, about that woman with the green trousers just going to wash me, which is great. And I'm going to get my makeup on, which is even better because I'm going out for a bit of a coffee with the speech therapist. But it's really fascinating piece of work.
Yeah.
Actually, really thought-provoking.
Yeah, I think what was interesting with the timetable, because of course on their timetable the only things that were put on it were your physio session, the OT session, the speech and language session, the psychology, those kind of bits and pieces. What wasn't put on was, in the morning there'll be washing, dressing. Now you're going to walk to the lunch. Going to walk. So there was nothing visible on that timetable that said this is actually part of recovery. This is part of your practice. The only thing that was on the timetable was a formal structured session, OT, whatever. So there wasn't any visibility of that. The sessions, some happened on the ward, some happened, so they knew they were sort of doing washing, dressing, but I think that conceptually, that idea of this is about recovery, this is about practicing those movements and pathways and all those kind of bits and pieces, is a really high conceptual level that we're then trying to get people to understand at a time when they're tired, they're fatigued, they've got everything else, they've got very limited cognitive capacity, even if they've got no cognitive impairment. For something that's actually conceptually quite a hard thing to understand in the first 2, 3, 4, 5 weeks after stroke. So it doesn't surprise me that it's not links that they are making at that stage. So obviously it's working then perhaps with family members who might have more of a capacity to take that on board, that stuff which they can then feed in to their sort of family members and things. But you're asking someone to, say, take on something quite conceptually different from the last 40, 50 years of what they've understood about those type of activities. And I think it's that sort of thing about education. There's two different bits. There's giving information and actually giving information in such a way that people trust and believe in that information. And those are two fundamentally different things. That's the thing we hear endlessly. We need to educate, we need to educate, we need to educate. We can give lots of information, but it's not heard, trusted, believed and understood. And so it's really thinking about how do we get to that stage of enabling that. So it's not just about giving more, it's thinking about actually how is that taken on board by the people? How can we get to the point of belief with that? And I think that's so much across the board in healthcare advice. Endlessly people can get advice, but if they don't trust and believe it, we're never going to change practice unless we trust and believe what we're given. So how do we enable that stage to happen? And I think that's the exercise. So we can do, stroke information groups, we can do it in group, we can do it one-on-one, we can do whatever, but that's just about giving information as opposed to actually helping people get to that sort of point of belief at that stage, which is hard to do, but unless we get there, they're never going to change and go with it. So
it's really difficult though, because you don't know we don't know as professionals what their end point is, and you hear all the time people saying, well, I don't want to give false hope, which I hate. I would rather give people false hope than remove hope, like you say. But because we don't know, we can't be sure, so how do we...
Yeah, but I don't know about that. We don't know, but we do have a good sense, I think, with many of our patients. And I think not saying anything as well, when you then go to speak to people at home and you look at their sense making and how they're interpreting it, that's a really deep, dark place for patients to be in. And they really struggle, and therefore not having any visibility and not knowing. They will do the sense making in some way, whatever way they can. They're not just sitting there passively, just letting the world kind of wash over them. They're doing a whole heap of trying to make sense of what's happened to them. So if we don't have any conversations about potential future and things, they will do that, and we're leaving them, I think, just incredibly vulnerable to very, very dark moments at home. I just think it's not a passive type of thing. There's lots of active sense making, and therefore we need to think about those kind of conversations. And I say it's not taking away hope, and we can do, but it's how do we do that? But equally by giving them something to hold on to for what their future might be, because they get to a point of realization at some point. But often it's not with us, and we don't see it, and we don't know, therefore, how hard it is for them. So I don't know is the answer, but I feel we probably need to say more than we do, is my gut feeling.
Go on, one last one. I'm going to go with Catherine.
Thanks. I was just thinking about the timetable and about the self-supported rehab at home and how that's not successful, and you give loads of reasons about why, but maybe your timetables are too busy. So if we want them to do it at home, we need to teach them how to do self-supported rehab. So maybe in our timetables we should be doing that, so that they can reap the benefits of it, feel safe doing it on a ward. and say that this is going to be something to continue
Absolutely.
on and
Yeah.
on.
Yeah, I couldn't agree more. We have to make it, when they're in the rehab unit, that really visible, and invite them into that self-supported space in a much more active way, my feelings, in the rehab unit, because it's not a space they're going to step into by themselves, and therefore we have to help them into that space and give them the confidence and competence to be in that space so they can do something then when they go home. So I couldn't agree more that on that timetable there needs to be that spaces of self-supported practice, but really then helping, really thinking about enabling people who are fearful, who are sceptical, how can they be in that space successfully at that time. But I couldn't agree more. We actually actively need to help them get into that space at that particular time, and let them navigate it and let them fail a little bit, but in a safe environment. What could you do? Go the next day, and have a look, and then unpick it and spend some time with them in that way. What I often saw in the rehab unit, and it was lovely and it was brilliant, but they would be doing this kind of behaviouralist approach of just keeping going with that environment right until the day they were going home. And then on the day they were going home, it's like, here's your exercises, and they're all lower limb because we don't really know what upper limb exercises to give you, and then go away and all this. And it was literally just piled them at that last minute, and there was nothing building them up to that. And that's where I say we need to make a distinction. And I think often from my work, they've sort of fell into three groups. Those who were going to go home, who were basically going to happily get on with life pretty much as it was before. Those who are going to go home much more profoundly impaired than they were before, but weren't particularly seeking ongoing rehab, and then really picking out those who we know we want them to be doing, or they want to be doing some type of continual recovery, and it's those ones that we need to really focus on. How can we help them into that self-supported? And when I watched what was happening in the rehab unit, there was no distinction between those three groups about actually how it was being delivered in the rehab unit, where actually they had three distinct needs on going home, but when you watched, there was no difference in what was delivered for those three particular groups of people. And I think, we need, and it's not for everybody, so almost that kind of, 6 hours a day, 3 hours self-supported practice, that's not going to be for everybody. It's really picking out who is that for, and therefore how do we help them achieve that.
I think we could be here all night with questions. So let's all head out to the
Yes,
wine.
go get that
Thank you so much.